Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. My guest today is Jay Nakashima, the Executive Director of eHealth Exchange. The eHealth Exchange is the largest healthcare information network in the country and now is a designated quality health information network under the TEFCA, for lack of better words, TEFCA network rollout, which has been built over the last 6+ years, and now the data's starting to flow. Jay, thanks for joining me on this episode of the Tate Chronicles.
Oh, it's my pleasure.
I know the whole concept of the electronic exchange of healthcare data is certainly not a new concept to any of us. The early stages involved, though, often geographically focused regions. We had the RIOs and the HIEs that were often data silos themselves, but now we seem to be moving toward a network approach. But first, let me ask you, please tell me a little about eHealth Exchange. Why was it formed? What is its mission? And who are its partners?
Yeah, you bet. And if I leave any of that out, please interrupt.
You bet.
Yeah, so as I remember it, hey, when I worked for payers, back in the 90s, and then even we were actively rolling out EDI, electronic data and exchange, exclusively for administrative data, for claims, for prior auths, for eligibility, and enrollment, and so on and so forth. And of course, it really took off once Congress required it. And then, at the same time, the country was very actively exchanging lab results from clinical laboratories to providers. And of course, the technology then was HL7 version 2. And so, around 2006, the U.S. Department of Health and Human Services, specifically its Office of the National Coordinator, ONC, started a kind of a proof of concept project. And that was called the InHIN, or NWHIN, the National Health Information Network. That is the eHealth Exchange today, or what we evolved into. So we started out as an HHS project. Off the top of my head, we started with some real leaders across the country, the Veterans Administration, the Department of Defense, think Army hospitals, Navy hospitals, CMS, Kaiser, some HIEs like the Utah HIE, and so on and so forth. And they said, hey, we need to be able to exchange rich clinical information. And so after, a few years, when it came time to turn off the project, and HHS said, hey, this was a great success, we're going to turn it off. As I understand it, the players there, including the federal agencies, the hospital groups, and the state and regional HIEs, cried bloody murder. And they said, oh, no. We are relying on this 7 days a week. We cannot turn it off. So instead, HHS turned the National Health Information Network over to the private sector, and which caused the formation of the eHealth Exchange. So the eHealth Exchange is a nonprofit, public-private collaborative, and we're dedicated to the public good. And so at this point, we facilitate the exchange of about 21 billion transactions a year in all 50 states, for 5 federal agencies, for almost 300 hospital groups, for payers, for public health agencies in all 50 states, and then, importantly, for state and regional HIEs. So we've been, rolling up, we've been a network of rolling up data from those state and regional HIEs since 2006. So the network of network concept isn't new, but TEFCA instead is, adding the U.S. government's good housekeeping seal of approval to provide extra credibility for the data exchange that's happening today.
And let's just focus for a few minutes, not so much on the payer side, but on the provider side.
Yeah.
So there's one thing to get the, for lack of a better term, the plumbing down, an agreement, electronic agreements, to make sure data can be exchanged. But it's another thing for providers to actually partake of that data and do something with it. And so I guess that is more of the workflow process. And so just for a minute, let's talk about, of course, eHealth Exchange has now has been designated as a QHIN. So you're part of TEFCA. And so if providers are in Chapel Hill, North Carolina, where I am, and a patient walks in and they have access, perhaps through their EHR, will they perhaps query TEFCA, or will they have an agreement with eHealth Exchange? And, that'll be the front door into everything that includes the TEFCA networks. How does that work out?
Yeah, great question. And my response might make everyone's head hurt. But,
that's okay. Yeah.
But let me give it a shot. So, of course, it's complicated.
Mm-hmm.
But, yes, when providers perform treatment, they've got a patient at the on the table, in a bed, in a chair, whatever, and they need to decide what's the safest, most effective treatment that they can provide. And so, of course, they're going to want a patient history. And a patient's going to say, "Yeah, what meds do you take?" "Yeah, I take a pink one and a green one and a yellow one." I'm like, okay, well, that's not very helpful.
Mm-hmm.
So whether they tell you this or not, they are inevitably trying to retrieve a patient history. And typically their EHR is going to do this the night before or moments before a visit. And to pull back, problems, allergies, medications, lab results, surgical notes, et cetera. And so where do they get that data? The complicated part is it depends.
Right.
So let's say they want to pull the data from Mayo Clinic, who has 27 hospitals in 7 states, and they would do that probably because the patient said, "Oh yeah, I was discharged from a Mayo Clinic hospital or urgent care or whatever last week when I was on vacation." And so the provider in North Carolina in this example
Mm-hmm.
is they or their system are going to say, "Hey, we really want data from Mayo Clinic. Hey, if they're part of the eHealth Exchange, we'll query them that way." In that particular example, again, this is a hypothetical, so
Sure.
if I'm inaccurate, please forgive me. But I don't think Mayo Clinic is part of the TEFCA network yet. So if that is accurate in this example,
Mm-hmm.
the North Carolina provider is going to query eHealth Exchange.
Right.
Just our network. Now, if Mayo Clinic decided to connect to TEFCA, let's say through their Epic vendor who operates the Epic Nexus
Mm-hmm.
QHIN, then the query might go through eHealth. The North Carolina provider might query eHealth Exchange, we would know that Mayo responds via eHealth Exchange. And as an alternative pipe, we could also query the Epic Nexus QHIN, which is part of TEFCA. So it's crazy complicated.
Well,
But at the same time, it works.
Well, and so that's the question. If a provider queries eHealth Exchange, which is certainly one of the networks underneath the TEFCA network, it's my understanding, and correct me if I'm wrong, Jay, that if I'm a provider and I have a patient in the EHR and have demographics on them, I'll be able to send information into the network cloud, for lack of a better term, and numerous databases are going to be queried.
That's right.
Okay. Yep. And so, do you have any idea yet? I guess, one example is the question I asked about the eHealth Exchange, but then the fact that you have access to the TEFCA network, which you don't control, but you have access to it. What kind of time is involved in this if I do a query?
Oh, response times.
Yeah, absolutely.
Yeah. Surprise. Boy, I wish I had the metrics right in front of me. But it's incredibly fast. We're talking seconds. We're not talking minutes. And again, if I were a clinician again at the bedside and I had to wait, let's say, I'll make it up, let's say 3 seconds, 1001, 1002, 1003, I wouldn't be very patient. But the good news is that the vast majority of the queries, again, happen before the clinician steps into the room. So it's not a real-time query. It's moments before the clinician steps into the room.
Sure. And a lot of the QHIN technology, it seems like, and it may be different for the other aspects of data supply, the eHealth Exchange activates, for lack of a better term. But certainly for TEFCA, when a query is made, it's my understanding that data comes to what they call the edge of the EHR. How does that data actually get into an EHR? It's not going to be automatic, because nobody's going to allow third-party data to come in without being reviewed first. That's my belief. And so how does that data actually get to where a provider can look at that data coming in and decide to incorporate in the database? Is it EHR to EHR, or is it third parties that are going to handle that kind of functionality?
Yeah. So, of course, there are a lifetime supply of EHRs out there.
I know. Yeah.
But and I've worked for two of the big EHR vendors. But it's my understanding that the big EHRs don't use any type of surround system. So maybe I'll rephrase that. They may have what I'll call a surround or an edge system that initially collects the data, but that data truly is introduced into the core EHR.
Well, just I guess a couple of steps really before TEFCA and some other eHealth exchanges, attempts at interoperability involve creating certain types of file formats, like a CCDA. That could be exchanged and accepted, and the provider looks at that CCDA and actually decides, I guess until AI maybe comes involved or not, what part of that do they actually want to come into the patient's codified database?
Yeah. So, if I'm following, what I would say is that, in the olden days, so we're going back like 8, 9 years, I would look at EHRs, and the EHR vendors would just torture the clinicians. They would say, yeah, there was a CCDA, presented as a PDF, and you had to go to a special tab, pull up that PDF, which for a complex patient could easily be 100 pages long.
Right.
And you had to do something like hit Control F and look and search for medications.
Right.
But I definitely saw a trend. Let's say around 2016, where the big EHRs definitely presented the data, I'll call it, in a cohabitated fashion. So in other words, no matter what, if you are running one of the big EHRs and you want to look at the patient's medications, you would go to your EHR's medication page, and it would nicely blend, and it would show the medications that let's say the provider was already aware of. And then it would show the medications that another provider across the country had reported. And the EHRs even would delineate the two. It would say, okay, we here at this health system prescribed, I'll make it up, lisinopril. And so we're going to shade that in green or put a check mark next to it because we're positive it was really prescribed, and we even know if it was picked up. And then they might present another medication, whatever, that was supposedly prescribed across the country, and they might, color it in purple and put a question mark down there to say, hey, another doc reported this was prescribed, maybe even picked up, but we can't confirm it ourselves. So I do believe the major EHRs now do a nice job of displaying the data. Anything that can be discrete. So lab results, medications, vaccinations, problems, whatever, are put on the lab screen or the medication screen or whatever. But of course, if there are narrative discharge summaries, which might be a page or two long, and yes, those continue to be displayed as paragraphs.
Let me mention to our listeners, Jay, if they're just joining us, I'm Jim Tate, and on this episode of the Tate Chronicles, I'm speaking with Jay Nakashima, the Executive Director of the eHealth Exchange. So let me ask you your thoughts, Jay, on some of the what I perceive to be challenges to health data exchange or interoperability or whatever else we want to call it. This data coming in from all these different databases being queried, I would imagine that data often has to be cleaned up because there's duplications coming in of procedures, lab results. You kind of mentioned medications. So I know at the most basic requirements for QHIN under TEFCA, I guess it's there's a requirement that's more or less considered no frills. But some of the QHINs are offering additional functionality to clean up the data, strip out duplicates, stuff like that. How big a challenge is that, or third parties going to handle all that?
Yeah, it's absolutely a challenge. I don't think the right word is data quality. It's not quite precise enough, but that's the term I'll use today. And yes, I used to work for a national provider, and we had to connect with, 6,000 hospitals and hospital systems across the U.S. And yeah, when we would bring that data in, hey, XYZ hospital system, do you have medication? Do you have a history for patient J? Sometimes our system would choke on that data. I'll never forget the time we got an allergy for a patient, and it seriously was Tuesday, spelled out TEU or whatever, no code. And, so at least within eHealth Exchange, since 2018, so what is that, 6 years, we've required our participants to pass a data validation test.
Mm-hmm.
So for what is it, 6 or so years now, they have had to prove that the data they share with others uses industry standard terminology. So RX norm codes for medications, LOINC for lab results, SNOMED for observations, et cetera.
Mm-hmm.
They're all required fields are provided, and that the data is positioned in the industry standard required segment, so it's put in the right place.
One of the things, go ahead. I'm
And
sorry.
with TEFCA, boy, with TEFCA, that is all required, but there's no testing mechanism, so it's more the honor system.
I know one of the requirements for the QHINs under TEFCA is to enable, at some point, I don't know if we're there yet, individual access, which means really at the patient level. What is that requirement for QHINs to be able to enable individual access?
Yeah, so it was required the day that it was required in December of 2023 when the initial 7 or so QHINs, such as eHealth Exchange, were designated.
Mm-hmm.
So that's required today. The interesting part about it, and there were valid reasons, but the fascinating, the controversial part is that data exchange does not currently in TEFCA occur using FHIR. Instead it uses the traditional CCDA exchange mechanism.
Yes, I know FHIR is certainly on the path. I don't know if there's a designated timeline for it, but that's obviously the direction. Yeah.
Boy, I'm embarrassed to say the TEFCA Common Agreement came out, I don't know, 2 days ago, yesterday, really recently. And I don't remember exactly what it says yet. People on my staff luckily do that.
Yeah.
But eHealth Exchange does have FHIR, has had FHIR live and in production within our network, not within TEFCA, for a couple of years now. And we either do it in 44 states, 46 states, something in the upper 40s. It's 46. The big proponent of that is the FDA. The FDA exchanges via eHealth Exchange, and they only exchange via FHIR R4.
Whoa.
They do not exchange using CCDAs.
Great. Well, that's certainly the direction. I ran across a press release, probably sometime in the last month or so, Jay, that to help promote adoption and stimulate the exchange of eHealth data, that there's a incentive program to really attract more early adopters for public health data. Is that still in force? That's a big part of it, really to stimulate adoption. I think we're at that phase.
Absolutely. Yeah, we're really excited about that, and we're getting a really promising feedback from the STILTs, the state, territory, local public health agencies. Again, we already have connectivity with public health in all 50 states, but we're offering this incentive to get them to do so using TEFCA. And to also broaden the use case so they more actively adopt use cases such as case investigations, so they can kind of query back and push data back when necessary and make it bidirectional.
Jay, kind of hard to believe on my side, but we're almost out of time. But I want to squeeze in one more question, something that really always it bothers me on a daily basis, is that we have massive federal incentives, financial incentives for the purchase of and adoption of EHRs and the achievement of meaningful use. I'm not aware that there's a big financial incentive for the adoption and use of outside health data. Who's going to help providers really with best practices?
Yeah,
Thoughts?
you know, off the top of my head, there is a CMS incentive. So eHealth Exchange gives a lot of our participants the ability to satisfy, I think it's 60 of the 100 CMS promoting interoperability points that they need to get paid more. The challenge is that there are other, maybe it's not a challenge, but the fact of the matter is, I believe there are different ways of achieving those 100 points besides I'll call it HIE exchange.
Right.
Yeah.
Well, and I know that there is under the macro MIPS scheme, there is now, TEFCA access is one of the options. To me, yeah. So there is some of that, but certainly not what we saw with the big push of the adoption of the HRs and the training, just gigantic amounts of money. And so it seems like to me, the railroad tracks have been put down and the high-speed trains are coming with fire. But there almost has to be a change in culture a little bit on the provider side to get used to using that data and trusting that data, but time will tell us.
Yeah, I know we're out of time, but
sure.
But I do want to mention, hey, I remember 10 years ago visiting countless hospitals and countless clinics and talking to physicians and other clinicians and saying, hey, we've given you, this is when I worked for a national provider. Hey, we've given you this amazing clinical data from the outside world. And the response was often back then, I'm aware of that amazing data, but I don't have time to read it.
Correct.
Now what I hear from those folks is, I'm aware of the data. I still don't have time to read it, but I make the time.
Well, and once it becomes really a part of the place of care, place of service, that it just becomes part of what gets done. And I think we're moving in that direction. Well, before we're totally out of time, let me remind folks if they want to find out more about the work and the mission, the services of eHealth Exchange, they can go to eHealthExchange.org. Pretty simple.
That's right.
Yeah. To our audience, thanks for joining me on this episode of the Tate Chronicles. Offer a special salute to my guest today, Jay Nakashima, Executive Director of eHealth Exchange. Jay, thanks for coming aboard today.
Thanks for having me. You
can find more information on this show's program page at healthcarenowradio.com. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.